بشكر طبعا دكتور صلاح نجا، دكتور هيام العجان، دكتور هلا الوكيل، وكل اساتذتنا في اسكندريه على المؤتمر الجميل ده وعلى دعوتي ان انا اكون معاكم النهارده. النهارده هنتكلم على ال ISPD guidelines in the peritoneal dialysis, في peritonitis in peritoneal dialysis اللي هي it's our nightmare in the peritoneal dialysis. And whenever we mention peritoneal dialysis, especially here because of our lack of experience شوية, always we mention the peritonitis. So yes, peritonitis is a common complication of peritoneal dialysis. It's associated with significant morbidity, catheter loss, transfer to hemodialysis, transient loss of ultrafiltration, and possible permanent membrane damage and occasionally death. The rate of peritonitis in peritoneal dialysis patient is variable across the world and across the centers. And the recent PDOPS has shown that there is a reported variation in the overall peritonitis rates ranging from 0.26 in the United States to 0.4 in Thailand, 0.4 episodes per patient year. So peritonitis is most often due to contamination of the pathogenic skin with pathogenic skin bacteria, with Staphylococcus epidermidis or Staph aureus for the majority of cases, and sometimes it creates biofilms that lines the catheters, and this leads to resistance of antibiotics and to refractory or recurrent cases. The cause of peritoneal dialysis, it's either the peritoneal dialysis related due to transmission of infection or exit site or tunnel infection, or secondary peritonitis, which is a bit rare but more serious cause of peritonitis. Over the year, the ISPD has published many guidelines for peritonitis, and there was a latest update early this year in March 22. So the peritonitis guidelines recommendation in 2022 updates on the prevention and treatment for peritonitis. First, definition and management and measurement of peritonitis. We have to identify the cause-specific peritonitis, the time-specific peritonitis, and the outcomes of the peritonitis. Second, and this is the most important part, is the prevention of peritonitis. Third is treatment, and it's starting with identification of the organism, empirical treatment, and then specified treatment and dose adjustments and antibiotic delivery and stability, monitoring the responses to peritoneal treatment, and when to return to PD after cessation of the PD. So starting with the definition, peritonitis is defined that it should be diagnosed when at least we have two of the following. The first is the clinical feature, abdominal pain or cloudy dialysis effluent. The second is dialysis effluent with white cell count of more than 100 or with 50% polymorphonuclear leukocytes, or a positive culture. This should be, the rates of the peritonitis should be checked at regular intervals, and all PD programs should monitor the incidence of peritonitis, and there should be a standardized metric to measure the outcomes is critical to the benchmark. So peritonitis should be measured as a number of peritonitis episodes divided by the number of patient years at risk. That's to say, the number of years of peritoneal dialysis starting from the time of peritoneal dialysis commencement, reported as episodes per patient's years. The PD commencement starts from the first day or the first time the patient starts peritoneal dialysis, whether this is at home or at the hospital. and the number of patients years at risk should be fully inclusive, counting even the days at the hospital. All the relapsing episodes should be considered as extension of the original episodes. It's recommended that a diagnosis of peritonitis according to organisms identified on culture, and then the treatments should be tailored. And we should, the time-specific peritonitis, we should identify when this peritonitis started, whether it's the PD peritonitis or it's PD-related peritonitis or PD catheter insertion-related peritonitis. And sometimes patients have peritonitis that is prior to starting the peritoneal dialysis treatment, and this is sometimes missed. We have to identify the outcomes, whether it's a cure or recurrent, relapsing. It's associated with the catheter removal, peritonitis associated with hemodialysis transfer, or mortality. So medical cure, if there is a complete resolution of the peritonitis. Refractory, if the peritonitis episodes with persistently cloudy bags or persistent dialysis effluent, leukocytic count more than 100 after 5 days of appropriate antibiotic therapy. Recurrent, it's peritonitis episode within 4 weeks of completion of therapy with a different organism. Relapsing peritonitis, it's peritonitis episodes that occur within 4 weeks of completion therapy with the same organism. Repeat peritonitis is episodes that occur more than 4 weeks after completion of therapy of a prior episode with the same organism. We should identify the peritonitis associated catheter removal, and as we have mentioned before this, we have to check the peritonitis rates across the center at least yearly, and all other parameters should be checked on regular basis, and the target peritonitis rates should not exceed the 0.4 episodes per patient's year. So prevention of the peritonitis, as this is our main task, is to prevent the peritonitis before happening. So we have to ensure using all the best practice available, catheters, lines, and fluids that we can use. And it's the single-use disconnect or Y system. Reports have demonstrated the reduction in the peritonitis with those lines. So we have to start with the catheter placement, exit site care, contamination of the system, and we will go through them all now. So at the time of catheter placement, it's recommended that systemic prophylactic antibiotics be administered immediately prior to the catheter placement. The overall benefit of the prophylactic perioperative intravenous antibiotics was confirmed by systemic review of 4 randomized controlled trials, and those trials have used the IV cefuroxime, gentamicin, vancomycin, and cefazolin. And also, although the first generation cephalosporins may be slightly less effective than vancomycin, yet it's still commonly used because of the concern about vancomycin resistance. So each peritoneal dialysis program should determine its own choice of antibiotics for prophylaxis after considering the local spectrum of antibiotics resistance. Exit site care is an important step in preventing the peritonitis in the PD patients by using topical applications of antibiotic creams or ointments to the PD catheter exit site. And still also there's this practice is varied across the different centers. Any infection or any change in the shape or in the color of the exit site has to be immediately reported and immediately treated. contamination of the PD system. If there is any contamination that the patient is exposed to, this should be immediately referred to the medical unit, and the PD effluent should be preferably be obtained for cell count, and sometimes, or at least, we have to change the transfer set, which is the external part that is attached to the catheter from one side and to the lines from the other side. If the patient is undergoing any invasive gastrointestinal or gynecological procedure, then it is suggested to have a prophylactic antibiotic and also a drainage of the PD fluid to keep the abdomen empty before the procedure. And those procedures lower the incidence of the infection. And it has been shown that the highest peritonitis complication rate after endoscopic or instrumental procedures is reported mainly after invasive gynecological procedures. Training, and this is the clue of a good dialysis, PD dialysis treatment. So whether how long or where or when, this is variable and it's left to each center, but it's recommended that the PD exchange technique and knowledge should be regularly reassessed and updated with an emphasis on direct inspection of practice of the PD technique. And there is guidelines from the ISPD also about the teaching or the training programs for the peritoneal dialysis. We have to start by teaching the patients, educating them how to start with hand wash, and a proper hand wash is a very, very important step in preventing the peritonitis in PD patients. We have to use all what we can use to help the patient understand the knowledge in the patient treating, whether it is visual by using pictures, maybe videos, diagrams, by auditory or using group education, discussion with the patients, read and write. They have to write their notes, write their lists, and they have to use some mannequins for exercising, or need to a hand-on approach to this will make the information just stick to their mind. Also, there's the hybrid PD education program with online video material has been developed and shown to be associated with lower peritonitis rates, yet the patient-doctor contact is very important. And according to this prospective cohort, there is the patients with high patient-doctor contact has better survival. They have lower peritonitis rates and less hospitalization. So patient-doctor contact interval of 2 months or less was associated with better clinical outcomes. So we cannot only depend on the remote education. Home visits. After training the patients, a specialized nurse should go and visit the patient at home and watch the patient doing all the technique at home at the circumstances that will be maintained later on. And this another retrospective cohort on the event of interest was of the first peritonitis episodes, and this shows that the patients treated in centers with a nurse specialized in PD or in centers providing home visits before dialysis initiation had lower risk of peritonitis. So the patient doctor and the nurse and the home visits, all this helps the patients stick to their right or proper technique. Also, there should be a refresher course for those patients, and target patients who have begun to, especially to identify the target patients who have begun to take shortcuts or simply deviate from the standard steps. After sometimes, the patients start to lose some of their disciplines in the peritoneal dialysis steps, and by time they make it's their habit and they are doing some mistakes. So by those reassessments, we can identify those mishabits and can be retrained. So, and the data indicate that most PD patients fail to follow up the full correct bag exchange procedure at the 6 months of PD, and this was a very old paper. Indications for retraining with anything that shows that there is some doing some bad habits, or there should be a technique breach, the patient should be retreated. After hospitalization, after peritonitis, after a change in their visual or mental or dexterity, acuity, following if there is the caregiver who are staying at home, if they left or changed, there should be a reassessment and retraining for those patients. So we should always emphasize on for updating the knowledge, and the technique should be used to address the benefits. Another concern is the patients who have pets, and this is a big number of the population. It's recommended that PD patients take extra precaution to prevent peritonitis if domestic pets are kept, and they should not be allowed to be in the same room where the peritoneal dialysis is done or the peritoneal dialysis equipments are stored. The direct contacts, they can even scratch the lines, and this can make some pores and introduce infection. And the cats themselves, they can transmit infections through their upper respiratory tract and their oral cavity. And they say that it's more with the APD than the CAPD, because with the APD, the patient is connected to the lines for a longer durations and sleeping at night, and some of them have their pets sleeping with in the same room. Some other modifiable risk factors like the hypokalemia and the histamine 2 receptor antagonists have been shown that avoiding them could help with the peritonitis. Now we move to the presentation and the management of peritonitis, and the patient should be aware to identify any change in the color of their PD effluent bag, and they should always put a paper behind the bags, and if they cannot read it, then it is cloudy. And we start by clinically evaluating the patient, start empirical intraperitoneal antibiotics, allow dwell for at least 6 hours empirically, and then after the culture we can reassess. Aminoglycosides should still be used, but not for longer duration, and it is suggested that the oral N-acetylcysteine could be used, and it could be protective. And this is a study on the effect of the N-acetylcysteine showed that both TNF alpha and interleukin 6 were significantly lower in the N-acetylcysteine group, and those patients had better hearing tests results in both ears after 1 month. And then according to the culture, we start modifying our antibiotic regimen. In the Staph aureus, we give treatment for 21 days, and after 5 days, if there is no clinical improvement, then the PD catheter should be removed. We go on with the other infection. It's always ranging between 14 or 21 days of therapy according to the type of the organism. In the fungal organism on the culture, we should remove the PD catheter as soon as possible and then continue with the treatment. Dialysis prescription should not be changed. Rapid exchanges, we can do 1 or 2 rapid exchanges before the PD, before the antibiotic dwell. This relieves the pain and reduces the inflammatory burden and endotoxin. And 1 minute, 1 minute. No.
Please, 1 minute.
Heparin should be added if fibrin strands are observed in the dialysate or where there is a history of clogging of the catheter, and it helps to lyse and or prevent the fibrin clots. Prescription should not be changed unless there is a hypervolemia, and usually with the peritonitis, the patient starts to be on the high transport side, so it might need some modification. We should not stop dialysis during the peritonitis. There were some theories that we should stop for 48 hours, but actually this does not affect. We should monitor the response to peritonitis and catheter removal if there is refractory or relapsing or fungal infections or abdominal problems. When to return to the PD, the patient is always still on treatment, and the simultaneous and the catheter, the patient just stops if the catheter is removed, and a minimum period in the fungal, or if there is an infection, a minimum period of 14 days, 3 to 4 weeks before the placement. And our target is 0.4 episodes per year, and this is the revision of or the guidelines that we have mentioned. Thank you.